Hi, everyone. Welcome to our FIER podcast. I am Emeline, a Master Fellow of the program, together with Dr. Adriano, Dr. Lucas, and Dr. Freddy. We also have our professor here, Dr. Flávio Rezende. Welcome. And today we are so happy because we have a very special guest with us. Welcome and thank you, Dr. Steve Charles. Dr. Steve is a great retina surgeon from the USA, and he's a teacher, he's an engineer, and he helped developing the constellation and so many things. So welcome, Dr. Steve. Thank you.
Thank you for inviting me.
And
I have to say a few words before we start. Steve is besides being a dear friend of mine, he's, I've been telling my fellows that this is the Michael Jordan of retina surgery, or the Kelly Slater of surfing for retina surgery, because you know I go to meetings everywhere in the world and I meet a lot of great guys, but there's no one that has been more influential than Dr. Charles in our day and age. And he's it's still being, he still saw 60 patients today before joining us. So, this is a perfect guest for us because the fire program, it's exactly what you preach, every time I see you. So truly appreciate your acceptance to our invitation, and I hope we're going to have a lot of fun tonight.
I'm sure we will. You're a great force, and it's an honor to be involved with anything that you're doing.
Thank you
uh,
so much, Steve. Go ahead, Emilian.
so to begin with, Dr. Steve, could you share a little with us what were the crucial steps that made you become who you are today?
Well, of course, it's the people that you're exposed to growing up that make the biggest difference. So, um, at one point, I thought I had sort of a novel career of doing surgery, engineering, and teaching, but in reality, my father was a college professor. I lived on a college campus growing up. Every night, there were college students, grad students, and fellow faculty members sitting around our dinner table with my mom doing the cooking. So I was around teaching all my life. I was a projectionist in the junior high. I showed his slides. I was very close to my maternal grandfather, who was Swedish and a mechanical engineer, and he was a diesel engine designer. So I'm an engineer, and I always wanted to be like him. He ran a huge factory and designed these ginormous diesel engines. And then my godfather, my dad's oldest brother, never had any children. His wife had very severe diabetes, and he was the president of the Colon and Rectal Surgery Society. He was the most respected cancer surgeon in ever, and so I was sort of his special. I was his godson, so sort of his kind of like his own child in a sense. And my paternal grandfather was also a famous surgeon, but he died before I was born, so I really wasn't influenced by him, of course. But surgeon, engineer, teacher. That's what that. And then I was very fortunate to work at a TV studio. So even though I was a mechanical engineering major, I worked as a broadcast engineer. So I built systems like you're talking into right now. Built audio patch panels, video patch panels, wired TV studios up, fixed, these huge recorders that they used in those days, the 2-inch reel. And so I self-taught in electrical engineering, but I studied mechanical. But I kept searching for what would be a useful, a thing that helps people. I'm not going to design a gambling machine or a cigarette making machine or a weapon of mass destruction. I'm just not. So there has to be some good that comes from what I do. And so I got the idea of going to medical school and designing medical equipment. And so when I interviewed at medical school as a fourth year engineering school, as a 5-year program, I said, I want to do engineering all through medical school. And they said, nobody's ever wanted to do that. They do engineering first, then med school, and then engineering, they never do it again. They just learn coding and billing and how to make money. And I said, no, I want to design equipment. So I showed up at Bascom Palmer Eye Institute as a freshman med student 1 week into medical school and said, this is what I want to do. And I never wavered. And Dr. Norton, who founded Bascom Palmer, gave me an indirect ophthalmoscope when I was a freshman student. And so I owe a tremendous amount to Edward W.D. Norton that founded Bascom Palmer. He called me into it. And so I lived in the lab. I built the ERG machine from scratch. I built the EOG from scratch. I built ultrasound machines. I did a ton of cat and monkey surgery. I'd operate all night when I was a medical student and then work all day taking care of patients. I was number one in my class the third and fourth year in medical school, even though I was not interested, quite honestly, in peds and cardiology and all that stuff. I just took care of my patients. So at the end of my second year of med school, Dr. Norton called me into his office and he said, I want to make sure your summer research is meaningful. He said, but before that, I want to ask you a question. Do you want to do a residency here? Because I never talked about that. I never said, hey, I want to get a residency. Can I do research? No, I just did projects, sometimes, many times, my own projects. And nobody told me to do them. And and I said, well, yes, sir, I'd love to go to residency here. And he said, do you want to interview at other programs? And I said, only if you want me to. And he said, you're accepted. And I said, do I need to apply? And I said, no, you don't apply for a residency until you're a fourth year med student in the US. And so at the end of my second year, he said, we had a faculty meeting, you're in. And you know, it's the top residency program in the country. So that got me a head start. And then I became interested in retina immediately. And my senior year of med school was all elective. So I did engineering at night at the University of Miami School of Engineering. I did neurophysiology, retina physiology all day. And I started at 5 every morning and drew the retinas with the retina surface. So I did retina, then physiology, and engineering for almost all my senior year in medical school. Wow. And so I got kind of a head start. And then I got another break. Then at Bascom Palmer, it was always the second year residents, a 3-year program, that got to do retina. But they changed it. So after I did mine, they said, oh, by the way, we're doing it the third year. I hope you don't mind taking retina again. I'm like, I'm all over it. And Bascom Palmer was the first residency program in the country to do intraocular lens. All of y'all are too young to remember this, but there was one called the Copeland that was shaped like this, where one of these little leaflets went in front of the iris and the other one went behind it. And so Norman Jaffe worked with Bascom Palmer residents, and we were the first residents. So I didn't do that because I knew I wasn't going to be a cataract surgeon. I said, tell you what, to the other residents, you guys are all excited about IOLs. You're excited about all these complex plastic cases where, you know, you stick one ear in front of your upper eyelid and your other ear on your lower lid for cancer. And I'm like, all right, y'all do those. I'll do retina. They hated buckles and they hated vitrectomy because it took so long. So so then Gass went on sabbatical and Norton had a cervical spine problem. So I ran the private retina service as a Bascom Palmer third year resident. And I did I did faculty buckles all year. And so then got to have there were 400 applicants to the NIH, to the National Eye Institute. And so I started the vitrectomy program there by agreement. So Norton got Montgomery to train me in exchange for looking for VEGF in diabetic retinopathy patients with PVR cases as the controls. So they've never done a vitrectomy in NIH. So I got the equipment, went up there. So even though that counts as my fellowship, the reality was I was my own fellowship mentor. I didn't have a mentor. And so I was mentorless. And so I invented endophotocoagulation and the B-scan ultrasound and endodrainage of subretinal fluid and fluid air exchange while I was at NIH. And then I finally moved to Memphis, which was in some ways a mistake, but here I am. So I've done engineering every day in some way throughout med school, internship, residency, and my practice. So I'm every Friday, Saturday, and Sunday, I'm sitting in front of this laptop working on projects for Alcon. I've got 200 patents. I've done over $8 billion in sales for them, about $1 billion a year. The mid-labs machine, the Accutome 8000, the first disposable cutter, endophotocoagulation, the Acurus Constellation, and now the Unity VCS. And so it isn't, I don't scribble little things on a napkin. I've produced engineering designs with products, with all the components listed, the vendors for those, et cetera. but I don't do normal things. I don't play golf, take vacation, watch movies, party. I don't do any of that. I haven't been on vacation since 1996. I only work. And that's 7 days a week. I have two daughters that are physicians, and one's a team builder, and I'm real close to them, but they don't live where I do. So I text them every night and talk to them on the phone on the weekends. But I don't do normal stuff, as they always tell me, like play cards so that's pretty much the story.
But Steve, so do you do this just because you have so much fun doing it?
It's a lot of times it's hard. It's a little lonely to sit in your apartment from Thursday night when I finish my last case until Sunday night and not see a single person I know, unless it's
Right.
the person at the drugstore or the grocery. And so I don't. It's a little lonely, and sometimes it's drudgery. And I'm not a religious person. People always say to me, "Oh, it's your calling." I must be on call forwarding because God has not called me. And so my view of it is it's responsibility. Tom Brady was quoting some famous sports psychologist, and he says pressure is a privilege, and I agree with that. Instead of saying, "Oh shit, I've got to work on this all night. Oh my God," I just do it. But to say it's a passion and it's so much fun, it's fun when it works. It's disappointing when it doesn't, or when a patent gets rejected. So there's plenty of rejection, like in sales. You try something and I think it's a fantastic idea, and Alcon shows it to 5 doctors. Well, I don't know if we need that. That's very disappointing. But I keep trying. I just keep trying. I never let up.
All right. The other question that I have is like, because of all these different assets of your training and expertise, it must be really hard to actually communicate with normal human beings. And to your point, sometimes you create something that you think it's amazing, then 5 surgeons test and say, "Oh no, we don't like this." Many times it's just because you can't, most people can't see far enough. How do you deal with this?
Well, part of it is a result of how you get in medical school, at least in the U.S. It's not about thinking; it's about memorization. So you memorize a block of information and better than anybody else. So the way I describe it, I say it's content versus concept learning. If you go to a really good engineering school, it's concept learning. So you understand things, because you can't memorize how to design something nobody's ever designed before, but you can memorize the name of every artery and vein in your body and every known bacteria and fungus that attacks us. You can memorize that. And so if you're a content learner, that what do you want to do? You train at a good place, you respect your mentor, and you do as you're told. And so, we've never done it that way. Like the medium-term PFO. I've done 1,300 cases. I had 2 guys to the Retina Society stand up and say, "That's malpractice. You shouldn't be allowed to present it." And Stanley Chang got up and actually argued in my behalf. And you heard him do that at Harvard and say, no. Yeah. And so, yeah, it's frustrating. There's more expertise in coding and billing than there is in understanding the physiology of the retina. I know what every freaking cell in the retina does, and I pay attention to that. Do I have to know that to do a vitrectomy? No. Do I want to know it? Yeah. I want to know every single thing inside the machine. I've been flying jets for 40 years, and now they teach flying jets more with what they call memory items. That's literally the name of it. So if you're in the cockpit and they say there's a right engine fire, you go A, B, C, D, and you quote back what you're supposed to do, and you do those real quick in the simulator, and then you look at the checklist. That's how you do it. Before, they're like, figure it out. Understand if it's in the such and such a duct, whether this valve should close and that valve should open. How's the oxygen getting in there to support combustion, whatever. And so they're not hung up anymore on teaching systems level, where you understand all the AC and DC circuits, hydraulics and pneumatics, like we did when I started flying. So I'm not going to study flying that way. I'm not going to memorize. I want to be robust, where if something breaks, I can fix it, or at least work around. But most folks aren't that way.
All right. So guys, please keep this in mind: concept versus content. And amazing that you mentioned this way, because this is, I teach fellows, pretty much every day. my fellows there, they already graduated from their fellowships in Brazil, and they're doing an extra year exactly with the purpose of learning concept.
Great.
So it's they have the content, but now they want to jump to the content. So you can actually understand more how retina surgery actually works when you actually
I'll give you
learn
a
concept.
very quick examples. I've had people say, "How do you inject PFO to 27 gauge?" It's 0.8 centistokes. Water's 1. It's less viscous than water. Oh, I didn't know that. I thought it was heavy. That's called specific gravity. It is. It's 1.8. It's almost twice as heavy as water. That doesn't mean it's more viscous. Oh, I didn't know that. Another one. It's a tough case. I'm using oil for the macular hole. Well, did you know that the surface tension of oil is 42 dynes per centimeter, whereas it's 70 for gas? Your chance of fixing a macular hole with oil is much less because the interfacial surface tension is less. For example, I use laser for hemostasis in a diabetic fracture attachment. Almost everybody uses diathermy. Diathermy is radio frequency energy. It kills tissue other than the vessel. Whereas if you use green laser, 532 nanometers with red hemoglobin, guess what? It absorbs there, but not in the surrounding retina. So you only coagulate the vessel. You can even treat on the nerve head if you have to. And people say, "Oh no, I was taught to use diathermy for hemostasis." Well, you know what? You're wrong. And it's because I understand the physics and to an extent the polymer chemistry. I'm no expert in chemistry, but I understand the physics. I understand how the machines work, and I just think you can push things farther down the road if you really truly understand for example, in medical retina, how do I tell our team? And I had fellow applicants here Saturday for our program. We interviewed 7 people Saturday. We've got another interviews coming up in a week or two. And I was telling them, are you worried about nurses and PAs injecting and taking your job? Because you should be. And I said, are you worried about optometrists injecting and taking your job? Why don't you learn pharmacokinetics? Why don't you learn the pathways? Why don't you learn the difference between the molecules? You went to medical school, you studied biology. Have you ever seen the Peter Kaiser chart with every single pathway on one side of dry AMD and every single, and there's 70 companies or 80 working on each one of these pathways. Learn that, understand it, and then you'll be an educated medical retina person. And in our country, we have to do both medical and surgical, unlike in Europe where you do surgical only or med only, pretty much.
Right. Yeah, that's it. Well, nowadays it's the shortcut generation. So they want the quick fix, the easy in, easy out, and that's what you're the perfect guest for us because this is what the FIRE program preaches.
Steve,
It's all about concept, guys.
So do you teach this team remotely from Canada? Is that how that works?
Yeah, so we meet remotely once a month. They come here a few times a year, and then I go there a few times a year.
Oh, great.
Because I kept my license in Brazil. So then I go, and then they are operating in their own center, their own patients, and then I every case I start I write notes, what's right, what's wrong, and then at the end of each day I issue a report. And that's how they get to learn. And then when there's like a specific surgical technique that they want to learn, then I can go ahead and teach them there or make them do the whatever let's say the autologous retinal transplantation and stuff. So that's how the FIRE program works for the master fellows. And then now we're doing this. We haven't released yet on YouTube, so we're recording episodes for a broader teaching, but always with the FIRE concept of learning concept, not versus content.
Perfect.
Guys,
may I ask you, Steve, when you list all the things that you introduced in vitrectomy, you basically made the modern vitrectomy like we know it. I'd like to know how was it at the beginning? How was the surgery at the beginning, and how did you get motivated to invent those things that make vitrectomy like we know it today?
There's a phrase I use in a derogatory manner when I call it aspirational innovation. Some guys will come up to me and say, "I want to be innovative." I said, "What's the product?" "What do you mean?" "Well, you have to have a product." "Oh, I want to start a company." "Well, what's it going to sell?" What? I said, "Companies sell things. So what technology are you competent in?" "Huh? If you're not competent in technology, how do you plan to invent anything?" So it isn't about intent. It's about problem solving. So if you embed yourself in the work and you don't fall in love with your own nonsense like any hustler would, and say, "Oh, I've always done it this way. This way I invented this. It's the best way." Nonsense. I used to lay on the floor on a mechanic's creeper and operate like this to fix giant brakes. When Stanley Chang invented PFO, I'm like, no. His way's better. We used to not know how to mix gas. Gary Abrams taught us, mix it so it's 25% SF6 and it won't expand. Adopt his idea. Machromer to an extent and Scapins to an extent were like not invented here, not good. That is bad. That's bad. I don't care if it's some guy I don't like or I think he's an idiot, but he finally got one thing right. I'm like, okay, let's do it. Everybody isn't smart every day. And so some people that have 52 stupid ideas and finally got a great one, listen to it. It might be the one that changes the game when you got a tough case. So I'm constantly listening to other people talk, listening to problems. So embedding yourself in the problems. I've had people say, "Oh, you like engineering so much. Why don't you quit surgery?" I'd be useless. I wouldn't know what the problems are. I got to go up there and have first-year fellows, learning how, messing up, and trying to solve problems, and have people send me horrendous cases that are all messed up and figure out some way to fix them. That's what pushes it down the road, instead of just saying, "Well, I just want to do floaters and shit like that."
And what is with everything they introduced in terms of let's say surgical steps? What is the one or the few things that you invented and created, introduced that actually you thought it was like the most valuable in terms of making it easier or faster in the vitrectomy world?
There's 4 or 5 things that are weighted equally, quite honestly. I mean, obviously everybody does endophotocoagulation for retinal breaks and PRP. Everybody does fluid air exchange. Everybody does endodrainage of subretinal fluid. Everybody does retinectomy. Everybody does forceps membrane peeling, scissors delamination, scissors segmentation, linear aspiration, disposable cutters. I would say that's the list of the main things we do every day. There's air gas exchange, air silicone exchange, instead of just injecting gas into an air bubble and having no clue what the frickin' concentration is. And so those, and then in terms of console wise, each one got more complicated. The first one had, a light source and a cutter. And the very first one I did was the Octotome 8000, not the 800. And that had the first linear suction and the first pedal go side to side. Go to the right for cutter on, frag on, go to the left for vacuum only. In addition to linear suction instead of on-off foot pedal like the Octotome 800 that Conor O'Malley invented. And then came the MBS, which is the first disposable cutter. And that's a big deal because that not only they're disposable, but they're self-sharpening. That's what the real big deal is. Mm-hmm. And then I invented fast fluidics by making tiny little chambers like a tweeter instead of a subwoofer so that they can respond rapidly to foot pedal constraint. So the Mid-Labs MBS machine was way faster than the Octotome 8000. And then the ASRS was way faster than that, and the Constellation way faster, and now the Unity VCS is even faster.
You're also involved in the Unity.
I wrote the whole block diagram for it in 2012, the whole game plan behind it, and they built exactly what I called out. So, I did not invent the 4-spot laser, but I invented the fluidics.
Okay, so Dr. Steve, I'm gonna add another question about that. What do you think is gonna be the next game changer for vitreoretinal surgery in the future?
In some ways, for example, people ask me, are we going to go smaller than 27 gauge? No. There's no magic material that has sufficient modulus, sufficient stiffness to do useful work inside the eye smaller than 27. If somebody made a 29 gauge cutter, it would be like trying to, take water out of your swimming pool with a straw. Not happening. So it's not about small and smart gauge. I built a robotics company when my dad died of a brain tumor, and I sold it to Stryker, but it was for skull-based neuro. So everybody's talking robotics. I don't get it. We do these cases under local anesthesia. The patients move. We don't get paid that much to do it. I don't know if the dollars are there. I don't think they are for expensive robots. And the robots that have been hyped up so far are truthfully nonsense. The ones from like Precise Eyes, the Zeiss Squad is a joke. It's 4 degrees of freedom. They recently published a paper, and they were honest. Mark DeSmit was honest. He said it took twice as long, and there was no benefit in the OCT images, post-op OCTs. So I don't think it's robotics. So where do I think the advances are coming? Biology. We have not cracked the nut. We have not figured out PBR. Methotrexate is poison that you give weekly that has a modest benefit, and the other people at Harvard, other than the guy who started it, are not really using it, which tells you something. If it was so great, the colleagues of Dean Elliott would use it. And Dean Elliott's a great guy, an honest guy. I trust him. And he did the right thing. He did a clinical trial instead of just doing a few cases and saying, oh, this is the greatest thing. So and PBR is not proliferative. There's hardly any mitotic figures. That's why cytotoxic agents like chemotherapy don't really do much. And yes, there's an inflammatory component, but high-dose intravitreal steroids is what Machromer was using years ago. Doesn't work either. And so it's excessive healing. So it's a keloid of the retina. And we're not going to, nobody's figured out a way to modulate it, except I have a big project at Alcon that I started with a retinal patch, an elastomeric retinal patch that eliminates gas and silicone, and it seals the cut edge of the retina where the tears are, or where a retinectomy is, or a giant break, and it seals the pigment epithelium off so the RPE cells can't get access to the anterior retinal surface. So I think that elastomeric retinal patch is one move in the right direction. It just almost like a biofilm approach to wound healing in diabetic ulcers and burn victims and that sort of thing, where they're now using biofilms to advantage. But of course, today everybody's in love with the trendy thing about AI. The problem with AI, let's take cataract surgery, for example. Oh, we're going to have a robot, and then AI is going to run the robot, and it's going to do surgery. So what's the training set? Did you train it on iris incarceration in the IA cannula? Did you train it in a radial runout of the rexus? Did you train it in iris prolapse? Did you train it in suprachoroidal hemorrhage? What about meiosis? What about floppy iris syndrome? What about posterior capsular rupture and vitreous loss? You'd have to have 1 million messed up eyes that train on each one of these, and every one of them has to be trained on individually and properly annotated. You can't have some guy in Hyderabad that's never seen eye surgery before annotating the image data set. It's a highly skill set thing. So in short, the whole thing, AI fixes everything, is not, it's utter nonsense. And for example, look at AI for image. Oh, AI is the answer to interpret images. Okay, so we have a country like India with abject poverty all over the place, numerous diabetics everywhere. What are we going to do? Well, we're going to use AI to read images. Excuse me, is the AI going to get in a car and go inject laser or inject a drug in their eye, anti-VEGF agent? Is it going to inject every 5 weeks? Who's going to do that? And where does the money come from? So you're going to sit in the castle and say, we read a bunch of images because we're short of image readers. You can read 500 images an hour. You can read 1,000 an hour. You can read 10,000 an hour if you're efficient. You can literally boom, 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 boom. You get tired after a while. But we don't have a problem with image reading. But it's the AI guys all hook up with the image acquirers and make a big production about it. So every meeting, you got to hear somebody talk about AI looking at 8,000 fundus photographs. I'm not impressed. So what's the biggest advance in retina in 100 years? Anti-VEGF compounds, no question. Who's the biggest hero in the history of ophthalmology? A gynecologist from Italy called Napoleon Ferrar. Fantastic. incredible. I mean, think about it. No allergic reactions, no resistance buildup, no adverse effects. Just an extraordinary success story, and it's just for AMD, for ROP, for DME, for RVO. So that's the biggest advance. So I see the advances coming from biology, not from better and better machines. I think the Unity VSGS machine is going to be alive and well 15 years from now.
And the visualization
Steve?
Yeah,
system.
that's why I was asking.
Steve, in terms of the one thing that I keep thinking that AI could help us, help surgeons in surgery, is through the 3D screens. Let's say, for instance, the Ingenuity being connected with the Constellation, now the Unity. Each step of the way, or depending on the amount of, let's say, pigmentation of the patient, the image could readjust and give you like the best quality of contrast or whatever.
You can do that. You're
these
right.
Type of things.
Yeah, they can do that.
Right. The enhanced.
But what it can't do is drive a robot, and there's guys
Right
now pushing for that and say, oh, well, we're just going to put OCT, for example. When you move a line in space like a pen, that's 6 degrees of freedom. X, Y, Z, translational, and roll, pitch, yaw, rotational. 6 degrees of freedom, not 4, like the precise size robot. How many degrees of freedom does OCT have? Okay, if it's a V scan, it has 2. It's a plane plus distance, and that's not enough. So we say, oh, we'll do en face. En face is artificial because the eye is shaped like this. It's flattened, so it'll, if you will, fit on the screen and then stack this way. It's not the way that it doesn't cut the way the eye's cut. It's flat artificially, and that's not real geometry. You can't operate off that geometry. Look at, for example, just you might find this interesting. I had tonsil cancer this year, so I had IMRT, and I did a lot of work on, not a lot of work, a lot of investigating, rather, let me say, on image-guided surgery, image-guided radiation therapy, etc. So people say, oh, there's image-guided neurosurgery. Actually, there's not. What is image-guided? Where is the image data set? What's the fiducials for it? What's the coordinate system? Where is it? It's in the box. It's in the CT box. It's not in the OR. So say, oh, look at these images. It's 3D. Hold on. Where is it on the patient? Nobody knows. Oh, we'll image the patient with little fiducials on their skin. On their skin, little things, a millimeter diameter when you're dissecting vessels and nerves that are 50 microns in diameter. Right. Excellent. So in fact, it's very, 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 very crude, and it can't drive a robot to do neurosurgery, even though bullshitters have been talking about it for 25 years. Various neurosurgery professors that know nothing about technology. It's scary. It really is. So now let's embellish that a little bit and say how complicated it is in retina. So is it image guided when, as soon as you open the calvarium, the average shift of the motor strip is 2.5 centimeters. 2.5 centimeters, CT and MR, 1 millimeter resolution. So guess what? It ain't where it was when you did the CT and MR. It's somewhere else now because of what? The D words: decompression, deformation, desiccation, diathermy. It ain't where it used to be. Okay, and people that don't know better say, oh, of course they do image-guided neurosurgery now. No, they don't. They replace the stereotactic frame with a robot that sticks a needle in for deep brain stimulation and lytic lesions for epilepsy. That's it for rhizotomy for pain. That's all. They just back out. Not surgery as we know it. So it's way harder than people think, and AI doesn't fix that because you can't have a large language model would never train on all the nuanced complications and indications.
So we can be hopeful that at least for now we're not going to be replaced by robots as a VR surgeon.
Never, not.
Thank you.
Excellent.
It's hard.
And Steve, in all these years that you saw so many changes in retina field, how do you think we have a lot of young retina specialists here listening to us, and how you recommend us to keep updated on so many changes, and how we should prepare for the next decades, and how you prepare to all your career?
if you let business types control your life, and if here's what happens, they say, well, if you go to the ASRS and the Club Joscanan and the Academy of Ophthalmology and the Brazilian Academy, you're way too much and you're losing revenue. No, how are you going to exchange ideas with people? So keeping track of terrific leaders and teachers like your boss here, that's what you've got to have one-on-one exchanges with them. Formal listening to lectures, if you learn it all from YouTube, you don't get it. It's better than not, but it's better yet to actually go people. I've had 4,000 or 5,000 surgeons come watch me operate. It doesn't happen anymore because there's people training all over the world. But I used to have 2 or 3 or 4 there every single time I operated. And they're guys that they trained with Scapins or they trained in the buckle era. So they were bucklers, but they weren't vitrectomy surgeons. So they came and learned how. And to this day, there's people, even if they retired 10 years ago, keep in contact with me and say, that was an amazing experience. I spent 3 months with you. I spent 3 weeks with you, whatever. Or I came back for a week every year. So go watch other people operate. And YouTube and iTube really help. There's no question. There's plenty on there. You always got to remember that it's the selected case on there. You don't put your bad stuff on there. But then, reading helps. But the peer-reviewed literature is very staid. It's very constrained. There's numerous things that I did that I couldn't get it through the peer-reviewed literature simply because the other guys said, well, we've never done it that way before. No kidding. That's why we're publishing it, because it's new. And so it's very hard. I wrote a paper on 1,100 eyes that the NIH statistician and an NIH retina person looked at every chart, contacted every referring doctor, and looked at as many patients they could. So I didn't pull the data. And what did it show? With stage 5 ROP, 1,100 eyes, 25% remained detached over long term. And of those, the vision was hand motion. I tried to publish that in Retina. Guess what? Tracy and Capone said, no, we get great results. Yeah, really. I have drawers full of charts at one time. I finally threw them away. That patients they operated on, that the retina was stuck to the back of the iris, and there was, and they told the patient, well, your vision is going to be coming back soon, and not hardly. It just doesn't work so well attached to the back of the iris, and so in short. Why did that not get in the literature? Because it would have hurt their business. And they're the other ROP experts, so they were the only ones allowed to comment on my work. That's a problem. That's a real problem.
Exactly.
And so in short, the peer-reviewed literature is useful, but not enough. You've got to exchange ideas with people. I've asked people who got down from the podium talking about XYZ that are friends of mine. I said, do you do this? Well, no, but I was a clinical investigator, so I told them I'd give the talk. I said, but you just gave a talk on it, but you don't do this. No, there's a better way. I don't do that anymore. And how many times have I heard that from friends of mine? Many. Mm-hmm. And so one-on-one relationships, one-on-one casual discussions, away from the podium, away from everybody's ears. That's very useful. And but the other thing is just to look at this like the fun of lifetime learning. It's not. Many people, I think, if they were given truth serum, if the phenobarbital or something, they'd say studying is a pain in the butt you do to get a job. A job is a pain in the butt you get money. The point of money is to buy shit and have people amuse you. I don't get it. No, I don't get it. I think there's nothing more interesting than the stuff I do every day. We walk around art galleries in the such and such a meeting, and everybody, oh, look at that, it's a Monet, it's this, that. Who cares? My dad was an art historian. Do I care? No. It's so obsessing with the things that put you in the right. I'm going to coin a term: style space. Oh, I'm in an upper class now because I'm a famous doctor. Therefore, I do symphony, opera, ballet, fancy art galleries, and I talk a certain way and I dress a certain way because that's who I am now. Really? That's it? Your whole life's a costume, No. Just roll up your sleeves and do some work.
Yeah.
Right?
So just make sure that I didn't ask Steve to say anything, right? Because the reason I'm saying this is because the fire program, exactly what you're saying. You know, it's crazy how you're like just, you
Well,
know,
good.
yeah. It's perfect uh, because
By the way,
you.
I don't need to give a lecture. I can just go on and answer questions, talk about stuff informally. I think it's better.
Totally. So I actually I prefer that we keep asking questions because
Listen to
it's been, yeah.
And I'll even throw out, I'll ask myself a question or two if you don't mind.
Sure.
Hey, Steve,
Yes, of
hey, Steve,
course.
why don't you do vit buckles anymore? I heard you did 8,000 in the old days. Here's why. One, do patients care about refractive error? Big time. Go to any IOL meeting. Do you think people care? Yeah, they care. They don't want to be a +2. I had cataract surgery in both eyes by a famous guy. I won't mention his name. I'm a +175 in both eyes. I had cataract surgery, 175. He measured me in 6 machines, 3 different times, used 13 algorithms on +175. Now, what happens when you start do an encircling element? You're going to induce, on average, the Ron Michaels paper, 2.75 diopters of axial myopia. So somebody's had LASIK, they get, and of course they're myope, and then they get a detachment, not because of LASIK, but because of being a myope and having lattice. And then somebody says, well, I just sleep better at night if I encircle them. And now they're -3 again. Do you think that's a happy patient? Not happening. So now the patient pays for their cataract surgery. They nail the refraction. They pay attention to Graham Barrett and Arthur Cummings and Warren Hill and all the superstars of refractive and Jack Holliday, and they get it right. And then the patient gets a detachment, which 1% of cataract surgery patients, round numbers, maybe 0.5%, go on and get a detachment. And then somebody encircles them, and now they're a -2, a -3. Are they happy? No. 50% of the patients get 40 as tropius. Not one patient ever came to me and said, oh, thank you for the double vision. I really enjoy that. I thank you so much. I get to see everything twice now. Thanks.
I can see
You know,
that.
no, nobody likes that. Now, and then they take the traction sutures when they do buckles and they drag them over the cornea, and then the epithelium turns to shit, and then they scrape the epithelium off. Do you think people like to have an epithelial defect that took 2 months to heal and have to wear a bandaged contact lens? Not happening. So ocular surface disorder. So the patient happens to get glaucoma, and then the glaucoma person says, you put an encircling element around my eye? Where am I going to put my Abed or my Barbell? You know, there's no place. I can't make a trabeculectomy, but the conjunctiva matinum's all plastered down to the episclera. So in short, learn to fix detachments without buckles. You have to use wide-angle visualization. You have to have the discipline to use scleral depression. You have to get rid of peripheral vitreous distraction. You've got to treat every break, find and treat every break. I'm now a huge fan with something I didn't think of called extended vitreous-based laser. And Dr. Blair from Chicago reported that in the Retina Society 3 years ago. It was unbelievable. I'm going to try to report the numbers as best I can remember. He had 65 patients with Stickler syndrome, round numbers. Half got extended vitreous-based laser, so light, almost confluent laser from the aura all the way to a couple rows behind the equator. So a lot, not heavy, light laser, but 4 or 5 rows. And he called it extended vitreous-based laser, EVBL. Okay. And the other half didn't. They treated only the tears. There was a huge detachment rate, like 25% in the people that didn't get it. And there was 1 or 2 detachments in the other series. It was a monster difference. And I heard that and I said, well, it doesn't just apply to sticklers. It applies to any high-risk retinal detachment setting. So because I think of PBR as a keloid, I was a minimalist. I say, oh, just treat around the tear. Don't do rows. I was wrong. Light rows, almost confluent. Light treatment, not burns, but just really light, like I did PRPs before we got anti-VEGF. That's what you want to do. So I'm a big believer in more laser, and I'm a big believer in not doing buckles. And so I get rid of the ocular surface disorders, strabismus, axial myopia, and trouble with glaucoma. And I think that's a real important lesson.
So you do 360, like let's say the laser goes posterior to the vitreous base.
Yes, sir. Posterior to the vitreous base. That's crucial. But carried anterior, so you don't get that toroidal so-called donut detachment that Harry Flynn reported.
Right.
And
that's important.
Is there any
there's
evidence?
another. Go ahead.
Is there any evidence besides besides stickler, or for regular recommend?
I do it for any high risk situation. I try to do that, and unless the patient's squirming on the table and uncomfortable or something, I do that in almost every detachment that I fix now. Not in an epimacular membrane case or a diabetic vitreous hemorrhage case, but in detachments.
Yes.
I'm doing more laser, and particularly in oil removal settings.
And I'm curious in terms of the laser parameter for this 360 and for cauterizing the blood vessel.
On blood vessels, I use I use continuous instead of duration control, because with blood vessels, with the hemostasis, they go into spasm, and you think you've closed the vessel, and you come back 2 minutes later after looking at some other part, it's back open again. Yeah. And then, so you've got to use continuous laser to truly, you got to heat it to 65 degrees centigrade, not that we can measure it, but that's known, in order to denature the protein, the hemoglobin, and the endothelial wall of the vessel. So to really coagulate, you got to use continuous. And that's true, like if you're trying to do Coats disease or something like that, or sickle cell as well.
And you set the power to how much?
Well, maybe not a lot, 150 milliwatts, something 150? Like that. Yeah, something like that. There's another thing that might be fun to talk about. Well, do we need scissors anymore? I've heard people who claim to be experts get on the podium and say, "Oh, I can't believe you'd ever use scissors for a diabetic traction attachment. The cutter will do it all." Find out not that you'll hear it when they're on the podium, if they use silicone oil. If you use silicone oil often in traction attachments, you're not doing a good job. And why do I specifically target silicone oil in the diabetic patient? Because silicone oil has a very low oxygen extraction ratio, just the opposite of liquid perfluorocarbon. Liquid perfluorocarbon holds 3 times as much oxygen per volume as hemoglobin. It is used for liquid ventilation for chemical pneumonitis, refinery fires and stuff like that. It's used for a blood substitute in Jehovah's Witnesses when you can't transfuse. So liquid perfluorocarbon, it has high oxygen carrying capacity. I'm not suggesting to use that in diabetics, but I'm contrasting those two materials. Whereas silicone oil has a very low oxygen extraction ratio. So when you do a vitrectomy, you've permanently reduced the viscosity 700-fold, permanently. And what does that mean? Because viscosity is a term of the diffusion equation. The partial pressure of oxygen goes up by 12 millimeters of mercury the rest of your life when you take the vitreous out. And nuclear sclerosis, for example, is an oxidative reaction, and that's why the cataract progresses. The NS progresses. If you got a clear lens, you don't get a cataract if you use high-quality infusion fluid. So I do 20 years old, 30 years old all the time when leave their lens in. Mm-hmm. But if you're 49 years old and you got 1+ NS, you're getting cataract surgery in 3 months. Mm-hmm. And I prefer the cataract surgeon do it and get the refraction right. So back to the diabetics. If you learn to use curved scissors and carefully delaminate, then you can do difficult traction attachments and sever those little attachment points between the sheet of epiretinal membrane and the retinal surface. But if you're going to try to do it all the cutter, trust me, you will make retina breaks. And when you start having 3 and 4 and 5, oh, it's a tough case, I had to use oil. No, it's a tough case because you made a bunch of iatrogenic retinal breaks because you don't know how to use the friggin' scissors. So peeling isn't the right thing to do because it's too adherent. Just like I've heard people say, "Oh, I have an ROP case. I'm going to do membrane peeling." You got to be on drugs to think that. ROP won't peel. It's as adherent as super glue. There's no way. And so anybody in an ROP is a disease to be prevented, not operated. Absolutely religious attention to the babies that are at risk in the NICU, and staying on schedule, never letting a week go by, and every 7 to 9 days at the very most, examining if they reach a certain level, treat within 48 hours, get on with it with anti-VEGF drugs, and then treat ischemic retina when they get a little bit older, about a year out, with light laser, with the LIO, not acute laser. But don't people say, "Oh, I'm a pediatric retinal surgeon." Oh, really? What do you do? 6 cases a year? ROP surgery should be prevented, not done. And the rare stage 5 where you can do a core vitrectomy and somehow save the lens It's a rare case. So it's a sign of failure of your NICU management if you're doing much ROP surgery. And I did a lot in the early days, but that's before we knew all this.
But Steve, why do you think that so many surgeons still do buccal vits? What is the reason? Why do you think that they're
Couple
still?
things.
Because I think my practice is the same way as yours. I do it very rarely. I do a combined buccal vit, very rarely.
I'll tell you the phrase that they use in the podium when I debate. They say, "I just sleep better at night." Mm-hmm. So it's about a tradition. It's about, gee, I wonder if I missed a break. But here's what I'd like to say to them. So when you do buckles, do you do straight buckles for detachments, which I don't do anymore? But if you do a straight buckle, do you think it's important to treat the breaks? Yeah. So if you just willy-nilly put an encircling element around somebody without identifying and treating the retinal breaks, please tell me what the mechanism of action is. They say, oh, it supports the vitreous space. Like what? Like bee pollen supports your immune system or what? And what does that mean? It supports the vitreous space. Well, before, when the patient was walking around the neighborhood, was it unsupportive before? It's going to fall off the bottom of their eye on their land in their shoe or something. And so I just don't get it. Let me tell you another one you might find interesting. The obsession with how long the macula is detached. However, Bill Ross at Vancouver, who created the whole retina practice in Vancouver many years ago, and a lot of Mabry and these other good folks trained with him and stayed there. And they've had a lot of good retinal surgeons for a lot of years. He did a really great paper with ultrasound measuring the height of the detachment. Okay, and then somebody else, and I forgot the author, about 2 years ago, repeated the paper, except did it with OCT, and so it's even more precise. Controlled head position very carefully, and then measured the height. And how can I prove to you that they were right? It's the height, not the duration. Central serous. Your macula can be off 10 months with central serous, and when you get it back on the patient's 20/20 or 6/6, if you say in meters. And so, now why is that? When the 98.5% of the outer segment is rhodopsin or cone pigment, okay? It's not a bag with a little cone pigment in there. It's a crystal, okay? Why? Because it's efficient. It's a trigger. So one photon makes one rod fire. One photon. And if 5 rods are hooked up to one ganglion cell, that's the threshold division. 5 rods, 5 photons. Okay, so they're a hair trigger mechanism. But when the one photon hits the 11 cis, the 11 cis then becomes pre-lumi, lumi, meta 1, meta 2, and paradopsin, and the retina, the vitamin A rotates off the opsin acceptor, attachment point. That's not the right word. Rotates off the opsin protein moiety, right? And now the opsin has been shown to be thermodynamically unstable. So now the protein moiety of the rhodopsin goes downhill once it's all trans instead of 11 cis. So you need retinine isomerase, which is RPE65, to regenerate the 11 cis from the all trans and restabilize and set the trigger to see a photon. And so what happens? Example, if you've got a detachment, I did this when I was a resident, and I actually almost got in trouble with Dr. Norton. There was a patient, and I was very interested in light tox. He said I did a big experiment where I took half the monkeys and kept them in total darkness, and with a detached retinas. I detached the retina on purpose with hyaluronidase with the Makama model, and then I left them in total darkness. The photoreceptor outer segments got longer than normal. And those were in the normal room illumination, on in the daytime, off in the night. It got shorter than normal, just like all our patients experience when they're detached. And so that's how I figured this out. So a patient comes along, and before I ever shined the indirect, I just glanced and I said, yep, total detachment. I over-refracted him, MAC off. So I over-refracted him because he needed about a +10 because the macula was forward. And I got him to read the chart at about 20/50 with the MAC off detachment. So then I got the Farnsworth 100 hue, and I took my 20 diopter lens and put it in front of it so that it magnified it, and they got normal color vision, MAC off. And so then along comes the third year resident. I was the first year at the time, and said, I measured the vision. You're an idiot. It was counts fingers. And so the retina fellow comes along after two people shined indirects to the patient's eye, and he says, "You're all idiots. It's hand motion." So Dr. Norton said, "Dr. Steve," he said, "how can you possibly not know how to measure vision when you've been a resident here this long?" And I said, "Let's patch the patient overnight and try it again." So we patched the patient overnight, took 12 hours of dark attack, and got him back to 20/60. And so in short, light is what makes cyclical normal illumination. Is what makes your photoreceptors go. So let's say you're in the ICU with a myocardial infarction, and you get a detachment. What do you want to do? Put a totally black patch on that eye to keep all of the light out, to protect those rods and cones. Now, we don't, that's an artificial setting, but it teaches you a bit about the physiology of retinal attachments, which I think is important to understand, instead of just saying, "Oh, well, it's okay to wait 2 days, but not 3 days for a MAC-off detachment."
And Dr. Steve, talking about retinal detachments, Dr. Rajiv Muni from Canada is doing a nice job understanding better the retinal displacement and visual quality after detachments. What's your opinion about displacements and how?
If you know how to do vitrectomy properly, you don't have the displacement that he talks about. Here's the problem. People do fluid air exchange like they did in macular rotation, in MT360. So they do fluid air exchange, and they haven't done simultaneous endodrainage. If you do endodrainage first, and the retina starts moving, I call it the reattachment experiment. You do endodrainage, the retina starts moving back like that. And then when it stops moving, that means you're recirculating fluid under the retina. Then you turn the air on, but keep draining, you won't get displacement. But people that do it wrong get displacement, and they say, "See, pneumatic's safer, it's high integrity." It's nonsense. It's about doing one of them wrong. It's like the PRO study said bit buckles are better than bit only. What was their success rate in their bit only series? 70%. And guys that were in the study told me fellows did a bad job in these cases, and the intending 70% is completely unacceptable for single surgery success rate. 70% is it's unacceptable, and the number should be 85 to 90. Pericles Bazidikos, the trained with Don D'Amico, he reported 90% years ago with 180 patients, and the guy from Greece. And so, in short, it's easy to say my way's better if you do a bad job on the other guy's way that you're using for comparison.
May I ask you?
You aspirate subretinal fluid under fluid, and then when the retina stop reattaching, that's when you start going to air.
Exactly.
And you still under the retina continue to aspirate until okay.
And then carrying that argument down a little farther, I mentioned the phrase, the reattachment experiment. So now the retina is going back and stops, and a little bit of air got underneath the retina. That's never technique unless you reflux by mistake on your foot pedal. That's not a surgical mistake you made. That's rigidity. You say, "Oh gosh, I missed some vitreous extraction. Let's do what? Let's do vitrectomy under air." You've got a curved interface where the peripheral vitreous is toroidal shaped like so. So you have to be very careful because it acts like a lens, right? Against air, but fluid against air with a shape like so. But you can then complete the vitrectomy, get rid of the traction. So the retina's kind of flopping around and you're getting nervous. Do endodrainage, then fluid air. The retina starts going back. Now the retina won't jump around. Complete the vitrectomy under air. Just be careful because the geometry is distorted. As if you looked in a swimming pool at an angle and tried to stick a spearfish in a fish, right? Well, normally there aren't fish in a swimming pool, but that wasn't a good example. In the water, okay? So now it goes back farther, and you say, and it was the high bullous detachment, and the two bulla open up. So, oh, look, a star fold. Do you have to take it out and start over and put PFO in the eye? No. Take the forceps and peel, quote unquote, under air. So then the retina goes back farther. Then it gets hung, and it's hung like this. Oh, a subretinal band. I didn't see that before. It was too bullous. Now I got rid of some of that turbid subretinal. You can see it. Take the forceps and punch through the retina, grab the subretinal band, take the illuminator, hold the retina back, and take the band out. Okay? Wow. And or at least part it. Okay? Then the retina goes back farther and say, oh, now it won't go back any farther. Air is going underneath. Retinectomy time. How much retinectomy? Enough to get the retina attached. And then if it's 270, go ahead and carry it to 360. But so I never do retinectomy. I invented retinectomy, and I never do retinectomy under fluid. I do retinectomy under air. So therefore, I do the right amount. Okay, and if it should bleed, I've contained it to the air retinal interface. But if you do it under fluid, you can do unnecessary retinectomy, or you can do way more than you need, or maybe not enough. So air teaches you in that technique of the retinal reattachment. So that's a standard method I've used for 45 years, and it works great.
Wow.
And when deciding for like radial retinectomies, and how is your usually approach?
Frankly, I think I underutilized radial retinectomy. I invented retinectomy. Montgomery invented relaxing retinotomy. So a point on that: don't leave the tissue anterior to a circumferential cut. But if it's still that ridge is standing up, if you make a radial cut at the end, it'll lay down better. And I haven't done enough of those. It's easy to do. I just got in the habit of continuing on with circumferential when I could have done radial. I'm really glad you brought that up. So I underutilized that for sure.
So just to recall again, so how do you perform the retinectomy under air? So when do you start going to air, and then
so I do that whole sequence: endo drainage, fluid, retina moves back, retina gets hung, starfold, peel, subretinal peel. Oh, retina won't go. So retina's too stiff. Looks like I need a retinectomy. Where the air went. So I make a little cut with the cutter. And if there's any big vessel, I take the diathermy and diathermize it first. But I don't cook the whole damn thing with diathermy like I'm, searing a tuna steak. I do discrete diathermy to breaks. It's okay to do more diathermy if you use just the pinpoint tip, so it causes necrosis, and then you excise what you've diathermized instead of leaving it. I don't want to leave a bunch of necrotic tissue there, is my point. So at any rate, then you extend that along until all of a sudden the air will go pop, and the air will come out from underneath the retina because you've released the traction, and the retina will lay down on its own. But don't put PFO in there, because the PFO or PFO, I love it, but it's also evil, because it lays it right, thinking of ways to get under the fovea. And it says, there's the fovea. Let's jump underneath it and trash the central vision. That's what PFOs do when they're talking to each other when we're not there.
So on a PVR case, you prefer going to air and doing the retinectomy versus using the PFO and then going to air after?
Yeah. I use PFO for giant breaks. I use it for standard inferior detachments. Leave it in for 2 weeks, take it out with the Alcon perfluorant. But you can't use the Indian stuff. It was made specifically to create uveitis. It was mixed halfway with curry powder.
And so, but sometimes when you go to air, your view is more impaired than when you have PFO in the eye.
And there's two specific cases for impaired view. One is you mistakenly took the anterior vitreous cortex out behind a YAG capsulotomy, so now you get fogging of the IOL. And that's not exclusive to silicone IOLs, but it's worse with silicone. Why? They have a lower index refraction, therefore they're twice as thick as acrylic, therefore they have a greater thermal mass, so they store the cold of the infusion fluid and have a greater chance of making condensation. So if you're fortunate enough to have had a YAG but not have interrupted anterior vitreous cortex, leave it to protect against fogging. Now, if you've had any Descemet's fold and it's an aphakic eye, then you can't do what I just said. You can't see a darn thing when the air is on the back of the cornea with defaults.
And in case I'm sorry to continue to pick your brain on this.
Oh, it's fine.
Because I don't I've done retinectomy under air, but it's rare. So today, for instance, I had a primary pretty bad PVR case that came in EOR, so I had no history. And during the case, I saw there was a high myope, and it had that little vitreous schisis layer that was super gluey and super hard to remove. Sure. And I had PVR and I had PFO in the eye. How would you have done it under air if it's possible to do it under air on the high myopes?
What I tend to do, if it's an inferior detachment in a myope, what I do is put the PFO in, If the vitreous comes to me, I take it. If it doesn't, I don't worry about it. I treat the retinal breaks. But when I go back in 2 weeks, I don't take the PFO with a soft tip. I take it out with a cutter, because guess what happens? A slow, gentle PVD happens over 2 weeks because the vitreous floats on top of the PFO. So it's a great way to gently, slowly make a PVD. Works perfect.
Gotcha.
Okay.
And what's your technique for hide myopics, macular detachment, and tractional macular detachment in those cases?
Well, with traction detachments of the macula, with vitreomacular schisis, I'm going to do ILM peeling with brilliant blue and the forceps membrane peeling, forceps ILM peeling. So I use only the Alcon Grishaber forceps, the ILM forceps, because why? They close at like so. If this is the plate that's 125 microns long, they close there first. Then when you squeeze, they close like that. They don't come together like this. That is fundamental. That's the whole principle that when I invented in-grasping forceps membrane peeling, so that's pinch peeling, right? That's this. You can't do that with blades that come together like this, like my fingers do. They've got to come together like that. So that and brilliant blue. I don't use membrane scrapers. Those are better known as neurofiber layer removers, and that's why I don't like those. Okay, and so that works fine. Now with macular hole caused retinal attachment, I've probably used too much oil in those in retrospect, because I went directly from normal macular hole surgery to doing a lot of macular patch grafts. I've done about 80, and a patch graft is impossible to do in a detached retina. It just is. And so I never really stopped in the middle where a lot of people did and learned how to do ILM flaps. So I think I have done ILM flaps over the disc when it had an optic pit related retinal attachment, and it worked nicely. But I think probably an ILM flap is best for those cases. I haven't done amniotic membrane that Stano Rizzo developed. He's a brilliant surgeon and an honest guy. I'm sure that's another good way to do it. So I would guess that ILM flaps or amniotic membrane are the way to go with macular hole related retinal attachments. But I don't claim to have a lot of experience in either of those two techniques.
Have you tried a macular buckling or
No?
the device?
That's the stigmatism from hell. That's like you take your camera and put an orange underneath the film and then take pictures of it. Yeah. Good luck with that.
Let me ask you two questions, Steve, Dr. Steve, please.
Sure. Everything looks like a basketball anymore. Well, even your face. Well, thank you. Thank you, basketball face.
When do you perform a phaco vitrectomy, and when do you operate buccal only?
Okay, that's good questions. Let's start with buccal only. I'll give you an example. I do hardly any, 1 or 2 a year, but I'll give you an example of somebody a couple of years ago. Pregnant lady, 5 months along, infratemporal detachment, both eyes, little demarcation lines, getting closer to the macula. I did under just a block, no IV sedation at all. So no risk to the baby or to the mother. I did a segmental buccal with hard silicone. I never used sponges. I hate them. And even though I was trained with them at Bascom Palmer, I gave them up the day I left and never went back. And so I put a little piece of hard silicone, 2 stitcher. It took 15 minutes per eye. I did both eyes at one setting with the new drape and buckled both eyes, got both detachments fixed. I had a guy that was, he had an infratemporal detachment, same sort of story. He wasn't pregnant though. And he had a board meeting in Europe. And he says, I can't have a gas ball in my eye. I'm not going to come back for 3 months. I don't want silicone oil, et cetera, et cetera. So I did it. So that's when I would do buccal only. I don't insert. I haven't done an encircling buccal only in 20 years, but I've done a segmental particularly infratemporal where they're easy to reach. Now, with respect to phaco-vit, America is completely different than other countries. And if you're in in South America, in Asia, and Europe, they do phaco-vit on everybody, including people with clear lenses that got 20 more years of accommodation. And I think that's unconscionable. But here's an example. I literally asked the top surgeons in individual interviews I was doing on my own. Alcon, I was the lead KOL for international. So I was allowed to ask these, not with them all in a room, Do you know who Arthur Cumming is? No. Do you know who Jack Holiday is? No. And I said, they didn't know. And have you ever put in a toric? No. So it became crystal clear to me that, yeah, they're taking the lens out because they know how to do good phaco and they're excellent surgeons, but the refractive outcomes are ridiculous. What's the axial length when you got a vitreous hemorrhage? Who knows? How are you going to measure it? You can't measure it optically. And if you measure with ultrasound, you're not sure what you're measuring from if there's a little layer of preretinal hemorrhage, for example. So if there's a total detachment, what's the axial length? Anybody's guess. What, do you use the other eye? Have you ever seen anybody that has a different refraction in one eye than the other? I have. And so I think, so what I tend to do, and mine's the other extreme, I said, okay, I went to New York and I spent 3 days with McCool. I went to Cincinnati before he left, and Sione teach me how to do phaco. And they came back and I said, do I really have a grasp of all the refractive situations? Which IOL is best for this? Which is best for that? When does monovision work? I said, no, it's complicated as heck, and I don't know it. So let's separate the functions. I'll send my patients to the best cataract surgeons in town. And so here's how I do it. If you've got 1 or 2 plus nuclear sclerosis or a cortical cataract that isn't blocking the visual axis, no problem. I'm just do the vitrectomy and fix whatever it is. Telling the patient, you're going to need retinal cataract surgery from an expert, and you can do that in 1 month. Now, let's say I can't see the fundus. If it's a bad news case where you got to do it, PBR, giant break, I do a lensectomy, but I leave the anterior lens capsule. And then I go back and put a posterior chamber lens and a 3-piece in the sulcus and get the refractive error correct. But in most instances, for example, somebody's got an epimacular membrane or a MAC hole, and I'll say, send them to the cataract surgeon, send them back 3 weeks. So they do that. I put 110-0 suture in the cataract wound so it won't pop open when I put my trocar cannulas in. And then I do, so I separate the procedures. Now, that said, if you're going to do phaco bit routinely, remember that if you do BSS plus and you don't put any additives in it, you're not going to get a cataract from vitrectomy. You're going to get nuclear sclerosis progression every single time. But if you're 20 years old and you had a foreign body or you had a detachment from lattice or myopia, you're not going to get a cataract. But now, if you cheap out on the infusion fluid and use BSS instead of BSS plus, and you put all sorts of magic juju in there, like antibiotics and epinephrine and a bunch of other crap in the infusion fluid, yeah, you're going to have mixing errors and preservatives and God knows what. And then you're going to start having so-called feathering of the back of the lens. And so I'm maniacal about using straight BSS plus without an additive.
Steve, since you do a lot of
just
cases,
1 second, sorry.
for phakics, how do you do the scleral depression? Do you depress for yourself? Do you have an assistant that depresses for you? How do you manage the vitreous base?
The vector from Alcon is very helpful for treating. Of course, it doesn't help you with vitrectomy because you got illumination. It's curved, and so you can depress with one hand and treat the breaks with another hand, and so scleral depress with one hand, treat with the other hand, and you got light, and that works. I'm not much of a chandelier guy. It's a 4th wound, but a chandelier is another way to do it. The chandeliers if you have air in the eye, there's a lot of glare off the IOL, which is the only part that bothers me about that. Gotcha. We have fellows that assist in really experienced scrub techs. I don't just use the hospital's one. We pay the scrub techs out of my pocket, and they've been with us, some of them for 35, 40 years. And so they're really good. So they can depress for you. But Alcon's got a product that's going to come out in a year, maybe less, that Gary Ganaban in Florida thought of. It's really cool. It's a T-shaped curved depressor, but it has an L-shaped handle it's malleable. So you put it in, depress a whole quadrant, and you put this against the drape, and you put a little piece of tegaderm on there. And so now you've got a self-retaining depressor, and they work great. And then Paul Hallen came along and put a fiber optic light on it. So it's patent protected, and it's an Alcon product, and it's called Sector, but it's not available yet. Okay. But I think that's a fantastic idea.
And Steve, one question, just coming back to the vitrector machine. how much do you think will advance in cuts per minute in the vitrector probe, and how is the more cut the best? Which you think is the limit for your experience in?
Well, I have a cutter design that's been prototyped at Alcon. It's funded, the patent already issued, that will go over 100,000 cuts per minute.
Wow.
The Unity BCS already goes 30,000. There's because that's so fast, you can't see a difference, but you can measure it.
Mhm.
So Brian McDonald, who works at Alcon, is a brilliant engineer, very soft-spoken, terrific guy. And he's set up lab experiments where it's just really clever. They took this very fine brush they used when they put optics together and used that to glue literally to vitreous. And then that was attached to a strain gauge. And then they have a stage, like a microscope stage that like the XY. And so it advances the cutter like this toward the vitreous. So you have an absolute measure of distance from the strain gauge, which represents the retina, real bovine vitreous with real collagen fibers that's fresh, and the cutter itself. And you move it in and in and in, and you measure and it turns out that force on the retina, acceleration on the retina drop, F equal ma, right? So the forces, the acceleration on the retina drop significantly when you go to higher cutting rates. So it's been shown, but it's so fast you can't look in with your eyeballs. Oh yeah, it's a lot better. It's like to ask somebody, say, how fast do you think that femtosecond laser was? Well, shit, way faster than my eyeballs. So, Yeah, femtosecond, yeah, really fast. I couldn't even see it go by.
So you guys tested 100,000 cuts per minute.
Oh gosh.
We will be able to do that, and we will see whether the flow rates are sufficient. Having a blade go by a hole instead of a hole by a hole is another way of saying a twin port, a dual port. That's in the public domain. Alcon doesn't own that, neither does anybody else. Other companies have that too. And but that is a good idea, the idea of so-called open duty cycle. So before we were all into all this duty cycle stuff, and in retrospect, it was ridiculous. It's far better to do, which I tried to do when Alcon bought Innovision from me, is a blade by a hole, but everybody thought it had to be a hole by hole. So you're obstructing the flow and then opening, obstructing, opening. So it's natural that it's a stuff jerk, 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 jerk.
Mm-hmm.
So faster and faster, faster is a good thing. But once you have a blade going by the hole, you're not obstructing the flow. You're just cutting off what's things going through there. And so the faster you go, the shorter the collagen segments. You minimize travel of collagen fibers before they're transected by the shearing effect.
Mm-hmm. Nice. So unfortunately, our time is up. Does someone want to do a last question for Dr. Stevie for today?
Steve, do you want to ask yourself one last question?
Because I get kind of hyper. One time, a guy said, "I got one question for you." He says, "What do you take?" Like, was it Adderall or nothing. I'm just.
You can finish with your retirement plan. What's your retirement plan?
Yeah.
Never retire.
Asystole. That's my retirement plan. If patients say to me, "What, are you going to retire?" I said, "If you come to the office and there's a casket in the waiting room, that'll be good."
Brilliant.
Steve,
Go till you can't go. Same thing as in sport, right? You go till you can't go.
Yeah, we honestly we can't thank you enough. It's
Fine.
This is a master class for sure. It's so good that we didn't. Dr. Charles had a lecture prepared, but it's pointless because
we'll have to do another time.
I have a proposal. Let's do it again.
We need to do again.
All right.
Yeah.
All right.
Just for the
Part
class.
two.
Everybody,
Part two.
you got a great guy here, Flavio. Man, you're the best.
Thank
Thank
you
you,
so
my
much,
brother.
Steve. Thank you
Be
so
well,
much.
guys.
Thanks.
Bye-bye.
Bye-bye.
Okay. Bye-bye.